Development Director at Tested Limited that manufactures the Tickplex test kits. Presently, I am the moderator for this webinar, and I will be giving you a quick introduction so that we are all on the same page. I couldn't be more excited about organizing this webinar because we have over 80 attendees from 18 different countries. We have today with us Dr. Leona Gilbert, the founder and CEO of Tested Limited in Finland. For more than 20 years, Dr. Leona Gilbert's research has focused on understanding how common viruses and bacteria promote or cause chronic conditions like autoimmune diseases. She will be talking about the current pitfalls for tick-borne disease diagnostic tests, what is Tickplex and its clinical relevance for tick-borne diseases, of course, also the clinical performance of Tickplex. She will briefly also touch upon the validation process for Tickplex from a legal and regulatory standpoint and how Tickplex received its CE and IVD marking for professional use in Europe. On the other hand, we have Dr. Armand Schwarzberg, the founder and CEO of Armand Labs in Germany. Dr. Armand is a medical doctor and specialist for laboratory medicine. He has been at the forefront of tick-borne disease research for more than 20 years. He is an expert in diagnosing and treating infectious diseases. Dr. Armand will explain from a clinical standpoint the advantages and disadvantages of Tickplex and other diagnostic test platforms. Also, how Tickplex and other diagnostic test platforms may be utilized to support the clinical diagnostic process for tick-borne diseases. Now, with that being said, it is important to note that like any other diagnostic test, the role of Tickplex is not to replace the clinical diagnosis process that is performed by healthcare providers, but the role is to assist in that diagnosis process. As for the format for this webinar, Dr. Leona and Dr. Armand will be speaking both for 20 minutes each, and then this webinar will be open to questions from you, the attendees. Approximately 25% of participants in this webinar have previously used Tickplex, so both the presenters and attendees can expect to see interesting questions that represent hand-on experience with Tickplex. So please feel free to write down your questions in the chat section and mark them as questions so that I can pass it on to our presenters for answers. Lastly, at the end of this presentation, you will be directed to a very short and concise survey regarding requesting your opinion about the quality of this webinar and any unanswered questions that you may have. Your answers will help us greatly improve our next webinar, and therefore I request you to take 2 minutes after this webinar has ended to answer the survey questions. Thank you for hearing me out. Now, Dr. Leona Gilbert will start presenting.
Hello, good evening on this side of the world, and good morning on the other side of the pond. Thank you for joining us in this webinar, #NotJustLyme. I wanted to include that. I'm going to actually start with our motivation of our company Tested in my research group at the University of Jyväskylä and what drove us to actually develop this test kit. And as Kunal has mentioned, I will go over the insight of the pitfalls of the current diagnostic tests, introduce Tickplex, its performance and validation. So I hope that you can follow with the screen, and let's begin. So it was interesting in getting started in this area. I did a lot of research to understand actually some of the pitfalls in general about chronic conditions, and also the reasons behind people developing these chronic manifestations because of common microbial infections like viruses and bacteria. And I picked up this citation here from the World Health Organization. 64 million deaths in 2015 occurred because of a lack of proper healthcare services. And this means that even lack of proper diagnostics and proper treatment protocols for a lot of individuals. And it's interesting to add to this, WHO has also indicated that 45% of the global population even lack access to these common healthcare services that you and I are used to, and that also includes diagnostic kits. And because of these statistics, we're really passionate about trying to improve this, and we thought that we would start with tick-borne diseases. And as you know, when the tick bites an individual, it will pass multiple microbes to the individual. And these multiple microbes, if you're not tested, you could succumb to a lot of these microbial infections, such as Lyme disease, as you know, neuroborreliosis, tick-borne encephalitis, relapsing fever, just to name a few of these co-infections coming from a tick bite. So I want to start off saying that a tick bite, it's not all about Lyme. It's not just Lyme anymore. And please use that hashtag. But even to add to the kind of statistics here, every 120 seconds, someone in Europe, including Finland and Sweden, Norway, in Europe, someone in Europe is being diagnosed with tick-borne diseases. If we think about North America, that's every 96 seconds. And if you think about China, this is every 2 seconds. And this is interesting, these statistics, because it's really telling us that tick-borne diseases is a global problem. And if you look at this map here, you can see the yearly number of patients reported that actually have a tick-borne disease. And it's interesting that some of the statistics that we have here, I'm sorry, I have to just start here again for a second. 1 second. Can you guys, I hope you can see my full screen. What are they doing? Okay, 1 second here. I think I was told that you can't see the full screen here, so I'm going to see what I can do about here. But let's see if this is okay here. 1 second here. Okay. How about we turn to a PDF? It's always good to have a PDF here, and we'll go to view and enter full screen and go back to the PowerPoint here. Okay, so I was here on the yearly number of patients reported, and you can see here that actually tick-borne diseases are in 80 countries all over the world. And these numbers, as you can see here, are interesting. If you look at Australia, what's reported are actually 0 cases, and it's very difficult to understand that tick-borne diseases are not being reported there. WHO has also indicated that these numbers are grossly underreported. So 1 second here. We're having a technical difficulty apparently because we're not able to see exactly my presentation. And I just wanted to actually look over the numbers here, that if you look at the numbers in North America, you can see that actually we have about 1.9 million reported cases annually. And then if you look at actually Europe, you can see that it's been reported 1.5 million or sorry, 1 million patients that have been reported to have a tick-borne disease. And if you look at Russia, that's 1 million. And if you look at even, as I mentioned, other like Africa, as well as South America, those cases are not reported because there's no standardized reporting protocols to actually get these accurate numbers. And it's interesting with in Japan, there are actually numbers being reported, and it's 1.1 million patients that are actually being seen that have a tick-borne disease. And not to mention this 84 million patients in China that actually have a tick-borne disease. So these numbers are really relevant. And just to add the numbers of relevance here, by the way, I have been working on trying to get this PDF uploaded because sharing's not working. But anyways, I'll continue with some statistics here before we actually get this working. Another statistic of interest is that by 2050, 35% of the global population will have a tick-borne disease, and this is actually based on Dickinson 2017, and also if you use the statistics that's presented in the citation of Dickinson, you can really see that actually these are actually really relevant. So, and I hope that you can actually now see this. Okay, so I'm now going to move on because I hope that you can see my presentation. And to add to the problem of tick-borne diseases, it also has been mentioned that actually patient advocacy groups have testified in court that it takes 11 different visits, 11 different doctors, and up to 11 to get a proper diagnosis. And this is a horrible statistics for these patients. And it also has mentioned in the Davidson 2018 citation that governments are spending approximately 20 billion euros to actually manage these patients that are not getting a proper diagnosis when they first go to the doctor. So this is really the reason what is driving our kind of passion to do better. And also with current diagnostics at the moment, they're very slow. It could take, like I said, 11 different diagnostic tools to get a proper diagnosis. Individually, they are expensive. If you add actually all the costs up from 11 different visits, 11 different doctors, and so forth, they're not updated to the current scientific knowledge, and very specifically, they're not updated to think about that there's multiple microbes actually associated with these disease conditions. Because the current diagnostics are traditionally testing one microbe at a time, and we know that actually, especially Lyme disease, in tick-borne diseases, it's polymicrobial in nature. And one major drawback about current diagnostic tests is the citation that you see on the bottom right-hand corner, that the ELISA sensitivity hasn't really increased. Okay, and these are commercially available for professional use. ELISA sensitivity hasn't increased in the last 20 years. And you can see that it has reached up to 62.3% in sensitivity. And this is kind of outrageous because we need to do better than these statistics. So as we move forward, another interesting point about tick-borne diseases is that it's not just about Lyme anymore. It's not just Borrelia causing Lyme disease. There's a lot of co-infections, as you can see here, from the Babesia, Bartonella, different species, even of Borrelia, Brucella, Coxsackie, tick-borne encephalitis, multiple microbes that are relevant, okay, for tick-borne diseases. Also, because these individuals are suffering for a long time with these co-infections that are coming from a tick, unfortunately, their immune system is being compromised, and they're more susceptible to these infections, as you can see here, such as yeast, chlamydia, mycoplasma, even viruses. And this is what we have seen, and also others, not just us, but others have also seen these opportunities and infections in tick-borne disease patients. And the pitfall with diagnostics is that they're not really addressing these co-infections. Some test kits will do a few of them, but none of the current diagnostics are doing or even entertaining these opportunities and infections. And this is something that we can help with in this area. In addition to this, okay, we have seen with Borrelia that there are these pleomorphic forms, and pleomorphic forms meaning that there are these different forms that the Borrelia can have. You can see on the upper left-hand corner, the spirochete form is here, like a cork-like structure. And then you can see the next panel, the bleb and the loop, a little small kind of expansion of the outer membrane. And then in the C panel, you can see the round bodies. And the round bodies are circular in nature, and we'll go and zoom into this a little bit more in the next slide. But also, Borrelia can actually form these biofilm-like structures. And this is in an interculture that's actually published in 2015. You can take a look at this work here. But as soon as we dive into round bodies, you can really see actually in this panel, very close up, how from starting on the upper left-hand corner, that the spirochete is actually forming its round body. And I say round body because you look very, very closely, this round-like structure actually has a cell wall, and it's not lacking in its cell wall. It's quite clearly defined that it is there. And you can see that actually these epipanels, that the round bodies is induced in water, but then these round bodies are also induced in human sera. So none of the test kits on the market right now actually handle round bodies. And we have actually shown that these are clinically relevant. I'll give you some data on that. So what we have learned so far is that test kits for tick-borne diseases need to be considering multiple microbes, and they need to consider multiple disease stages all on the same platform with a higher sensitivity. And this is what we have done. We have put Tickplex diagnostic kit manufactured here in our facility to include 15 different microbes, and we test for IgG and IgM, and all on the same platform with a higher sensitivity. So far, Tickplex as a concept and technology has actually been CE and IVD marked, which means that we are following the EU IVD directive, okay, the current one, and also we're following the Finnish medical device law regarding healthcare and devices and supplies, also the current one, to actually validate our test kit and to show that the functionality of this. And in addition, and what is noteworthy to add here is that actually Tickplex Basic and Plus test kit. So Basic deals with just the Borrelia species alone. There's 3 different Borrelia species: Borrelia burgdorferi, Borrelia garini, and Borrelia apsili, and their persistent form are included. It actually tests IgG and IgM together. And then the Tickplex Plus, as I already mentioned, has 15 different microbes. We have the Borrelias, we have Coinfections, and some opportunist infections. And we're also testing IgG and IgM on one platform as well. And this technology has been protected by trademark, and also we have filed 12 patents, global patents, actually all over the world. But what's interesting about the validation process of Tickplex is that we wanted to do even better to add credibility to this test. So we have actually accredited our manufacturing processes through Lloyd's Register in UK, and we're following the ISO 13485 standards. And this standard, it's really good that medical device manufacturing companies have the standards, and we are certified for the 2016 standard of ISO 13485. Okay, so this is Tickplex at the moment, but of course, Tickplex has to be scientifically validated and clinically validated so that we can fulfill the CE and IVD requirements under the two directives. And I wanted to go into actually the scientific aspect of this right now. But just to highlight actually some of the sensitivity and specificity of our Tickplex Plus kit, you can see that actually for Lyme disease, we have a 95 sensitivity level and we have a 98 specificity level. And what has brought these sensitivity and specificity percentages higher is that we have introduced the round bodies, the persistent form, into our test kit. And I'm going to show you how they have actually increase those levels here. And then you can see the robustness of all the other microbes that we have in the Tickplex Plus test kit here. So we're hoping that Tickplex actually is used so that the patients can benefit from actually only seeing the clinician through the single visits. We're hoping that the one visit to the clinician, that they will get a proper treatment, personalized treatment based on this information of Tickplex, and that the patient will recover quicker because they're getting a diagnosis, getting tested so that they can be treated. And also we're hoping that Tickplex is used so that the government can save funding that prevent the chronic conditions or persistent conditions that are associated with tick-borne diseases, so that these don't get established within the patient population. And we're hoping that Tickplex can participate in updating the two-tier system, and in the sense that actually they consider multiple microbes in this diagnosis of tick-borne diseases instead of just just the two-tier system that is being used right now, the ELISA and then the Western blot. So at this moment, actually, I want to go into the science and just to note here that the science behind Tickplex products are actually recently published in a Nature journal, the scientific reports. Here is the QC code and also the citation here, Garg et al. 2018. And so let's think about actually what we did in this study. So what we did here, you can see it's a lot of text on this slide, but I wanted to just point out that we started with an inclusion-exclusion criteria, so 509 patients from the top here, and you can see that actually we use the CDC criteria by grouping these patients in acute, CDC, late, CDC negative, the term that's used for post-treatment Lyme disease syndrome. We also had immunocompromised individuals that had low CD57, actually knowledge about these patients. Then we have a group of unspecific patients, and then we have a group of healthy patients. And again, this is coming right from our published, so basically we group them according to the CDC criteria. And once we group these individuals to the CDC criteria, we actually did a bunch of studies with them and we them against the 15 different microbes. And you can see here, and I know this is maybe difficult to see, but the point is that in the A panel, we're showing that actually infections in these patients are enormously important to realize that around, I guess, 75% of the patients actually have co-infections. So this multiple microbe of these infections of these patients can actually be seen in panel B. But most notably, you can see in the bottom panel C that once we actually look at these individuals in these 7 categories, CDC acute, CDC late, CDC negative, post-treatment Lyme disease, and the immunocompromised, you can actually see that the CDC negative patients are not actually negative for IgG and IgM. They're actually responding to multiple microbes as well. And the reason why we showed this while we're concentrating on the negative is to actually show you that an outdated two-tier system is not working in the healthy control patients that we had here. And we can also show here that the round bodies are actually increasing the sensitivity. We're picking up actually individuals that have been negative before and are very specific for these round bodies or the persistent form. And that's actually seen more closely here. If you look at IgM panel here, 40% of individuals that we tested were negative, but 2% tested with spirochetes, just spirochetes alone. 13% tested for the persistent form, and then we have actually 26% of people responding to the spirochete and round bodies together. So you can see here actually it's noteworthy to have the round body or the persistent form in this test kit because it has picked up these individual patients that were negative before and not responding to the spirochetes on their own. And you can see this phenomenon as well with the IgG. If we look at the IgG panel, we have, again, 20% of the people are negative for IgG and for the Borrelia and the 3 different species of Borrelia. But we said 7% only responds to the spirochetes, but 13% responds to the round bodies, and outstandingly 39% of those individuals are responding to the spirochete and round bodies together. And this is showing that actually it's noteworthy to put the round bodies, the persistent form, into a diagnostic kit so we can pick up these individuals that are not showing on traditional test kits as well. And now another image that I wanted to just show is actually the whole phenomenon that these patients, yes, they're responding to multiple microbes, but the whole point is that they're responding to multiple microbes in the presence with an infection of Borrelia. So when they have a Borrelia infection, they have an 85% chance of getting other other infections as well. So they're responding to these multiple microbes here. And you can see here, some are responding only to one other tick-borne disease microbe, but individuals, a lot of individuals, around 10% of them are responding to up to 14 different tick-borne disease microbes or associated microbes that we are screening for. And that's interesting because if we're not testing for those other 14 different microbes, then these patients don't even have a chance to get actually treated for those microbes. And if you look at the C panel, you can see the individual microbes and what the patients are actually suffering from, as well as then the spirochetes and the persistent forms. So the take-home message of this slide is that if the individual has a Borrelia infection, they have an 85% chance of actually having another tick-borne disease infection or also a opportunist infection. And this is kind of like the scientific basis of this diagnostic kit. And we could not have done this without our collaborators, clinicians, and patients alike to actually allow us to screen for their antibodies in coming from these infections. And I want to actually put out a need of your help still. We would like to actually publish more case studies in regards to this tick-borne diseases and multiple microbes and also opportunistic infections. So if you think you can help us with this, that would be great, because we need more studies to actually, and more science to show that really this is a profound problem, multiple microbes that are associated with a tick-borne disease or even a tick bite. So I want to say thank you at this moment, and this would not happen, this webinar, without Armand's lab, and I would like to now give the floor to Armand Schwartzbach. Dr. Armand Schwartzbach, please.
Yes, hello, good evening to everybody, or good morning, or New Zealand, maybe still at night. I want to talk a little about practical points. Leona, thank you for your great presentation again. It's very impressive, and I think a lot of questions came up already, and I try to answer by my presentation parts of that. What we all have to think about, what are the principles of our immune defenses? We all are doing indirectly testings. We are not checking for the pathogen. So laboratory is not a proving laboratory, it's indirect testings. Proving tests would be, for example, a culture or PCR, but you all know how difficult it is to isolate pathogens. In reality, for example, PCR for Lyme disease is just 20% in biopsies, we know. So it's really difficult to isolate and do direct testings. In the principle of immune defense, the invaders coming in, a macrophage is detecting. This is a general immune defense principle. It's not dependent on Borrelia. The macrophage then presents to a natural killer cell, the Borrelia, and we have then maybe the discussion about CD57 NK cells, CD56 NK cells in chronic virus infections. On the other side, the macrophage presents the pathogen, in this case the Borrelia, to a Th0 cell, and this Th0 cell then splits into Th1, Th2 system. The Th1 system reacts by T-cellular immune reaction, and by this process Borrelia can be destroyed. This is not discussing now intracellular forms or cysts or round bodies or pleomorphic forms. The Th2 system, we all know it's very established in the medical world, in laboratory medicine. The Th2 system is dependent on the plasma cells. They produce antibodies, IgG, IgA, IgM, IgE, IgD. And by this process, the macrophages destroys the antigen-antibody complexes, in this case Borrelia, and in the end you have the mast cell and the histamine release. Now, to summarize that, what are the aims we are discussing about immune-competent cells? We're discussing about CD57 NK cells in chronic Lyme or chronic other bacterial infection. They are responsible directly for destruction of antigen antibody complexes. We're discussing about the Th1 system, the T cells, for example, ELISpot or Melisa, whatever you use. This can reflect the current activities for different pathogens. And we are discussing tonight, today, the Tickplex antibodies, the B cells, IgG, IgM. So you see IgA is missing a little in that, also IgD, IgE, we can talk later about that. The Tickplex has a functionality in the Th2 test system. This is now to describe a little an IgM. What is an IgM? IgM antibodies are the antibodies with 5 binding arms. It's a very big molecule. It has heavy chains and light chains, and it has some disulfide bonds. What is IgM responsible? IgM is responsible. It appears early in the course of an infection. It's a systemic marker, we name it, and usually it can reappear after further exposure, or for example, if you have reactivations or again a chronic persistent. The IgM antibodies, this is one of the advantages for a newborn. The IgM cannot pass across the human placenta, only the isotype IgG. So if you have suspicion for an infection of a newborn, you can do IgM antibodies, and if the newborn shows IgM antibodies, this is nearly pathognomonic for an infection of the newborn by this pathogen. These two biological properties of IgM makes it useful in the diagnosis of infectious diseases. If you demonstrate in a serum, it means always in what we learned in laboratory medicine, a recent or a current infection or intrauterine infections. Also possible, we have a lot of examples for rubella. IgG is a different immunoglobulin. We have 4 different subclasses. It can cross the placenta. That's a big difference. We have 4 subclasses, IgG1, 2, 3, and 4. And you see the percentages here of IgG1, 2, 3, and 4. IgG1 is a dominant subclass, and it also is a complement activator. An antibody is not reacting without complement. And you know, by some studies from Ray Stricker, a professor in America, who shows that Borrelia can inhibit the complement, that you come to, sorry, going back, that you can come to an IgG inhibition, and the immunoglobulins are simply not working in the patient by some kind of C3a and C4a blocking activation. The half-life time on the right side is very important to me. You see that the half-life times of the different subclasses is a very long time, 21 days, 21 days, 7 days, 21 days. Also to mention, in chronic Lyme or chronic bacterial infection, we find a lot of subclass deficiencies, IgG1 and IgG3 especially, so that patients cannot produce IgG, for example. These subclass deficiencies are secondary subclass deficiencies by chronic infection, chronic inflammation. Immunoglobulin G is a binding protein, can bind the pathogen by agglutination process. It can do opsonization, and it can do phagocytic activation of the cells. And it activates the classical pathway in a complement system, which I talked already about. And it can also bind and neutralize toxins. IgG plays an important role in the cytotoxicity and intercellular antibody-mediated proteolysis. And IgG can be also associated with hypersensitive reactions, for example, food intolerances. For me, it's very important to look at the half-life times. Half-life time means a measure of the mean survival time of antibody molecules following the formation. Usually it expresses the time required to eliminate 50% of a known quantity of immunoglobulin from the animal or human body. The half-life has a variation from one immunoglobulin class to another. And what you see here, that the IgM has a very short half-life time. That means within 5 days, you have 50% just of the concentration you had before. And IgA has 14 days half-life time, which is in the middle, and the IgG is a very long-term half-life time of 21 days. So the short-term markers in the Th2 system we actually can detect is an immunoglobulin M and an immunoglobulin A. IgG is really a long-term marker. So now what about Lyme disease and our problems, the trap? We have big problems with the standardization for antibody tests, and Leona showed already the sensitivity problems of the ELISA techniques. This is an overview to show you that in 1993, the first study showed by Schmitz that specificity of Borrelia antibodies is 100 or was 100% in that study, but the sensitivity is 66%. And this is a big problem we discuss more and more. The sensitivity, the specificity is a good specificity also in the antibody testings, and Leona showed data for Borrelia 98%, which fits completely into the average of all the paperwork we have. Then came this study by Professor Puri, which you have already seen. It shows that we have a really huge sensitivity problem also of C6 ELISA, of the conventional ELISA, of the Western blots. So for me, being laboratory doctor now for 30 years, for me, I cannot trust these test systems, and I cannot exclude chronic Lyme by negative Western blots or negative ELISA. This is a slide where you can see all Lyme testings. I put that together to discuss it a little. The ELISA has, in my opinion, a poor sensitivity and a poor specificity. Why? Because ELISA very often is cross-reaction in the IgM and IgG for viruses, EBV, CMV, parvovirus 19, herpes simplex virus, and we find a lot of these. The CD57 cells we've talked about has a high sensitivity, but it's not a specific marker we know nowadays. It's a screening test for chronic bacterial infections. The C6 ELISA has, similar to the conventional ELISA, a poor sensitivity and a poor specificity. We are doing now in Germany a lot of microarrays. For example, we're doing Sera spots. The Sera spot has also, again, a poor sensitivity and a high specificity. Poor means for me 40–50%. This is not good. A test system in general in laboratory medicine, which is less than 80%, is a bad sense or a weak sensitivity. Test systems should have over 80–90%. Then laboratories are happy with that. And the Tickplex is now coming in this. It has, in my opinion, a high sensitivity, as Leona showed you, around 95%. Also, it cannot be 100%. No test system in the world is 100% in all laboratory tests we are doing in the world. And for me, it's so important to screen in my clinical experience or with some own patients for the round body antibodies now, because I can confirm that we find a lot of patients with round body antibodies, but not antibodies against the polymorphic form of the whole spirochete, which is in the Western blots. The Western blots, in my opinion, have a poor sensitivity and a high specificity, but we are now leaving more and more the Western blots. Western blots have the problem of a technical problem that you cannot standardize these techniques. We worked with readers, etc., but it's really a manual work, and it started in the 80s by HRV Diagnostics, and we're leaving more and more the way of Western blots, doing more microarrays. The PCR, as I told you, it reflects the current presence of Borrelia. It's possible, but in bloodstream difficult, because Borrelia doesn't like the bloodstream. It's not like malaria, it's not like Babesia. It can be in the blood surely for a short time in the cycling around, but it's difficult because Borrelia likes the tissue, and we can find, I think, better in the tissue, but I told you also in this just 20–30%. ELISpot has, in my opinion, high sensitivity and a high specificity, similar to the Tickplex. And the Borrelia culture, you heard about that. Borrelia culture has a problem of transportation effects. It's very sensitive to temperature differences and has all the big problems in contamination risks. The problem of the round bodies. I think it's so important to check for round body antibodies, and we cannot check for biofilms. Maybe, Leona, you have one idea to check for biofilms in a patient. I don't think we can produce antibodies against that, but I think it's really important now to check for round body antibodies. Round body, some of you name it L forms, cystic forms, persisters, whatever you name. The correct word, medical world, is pleomorphic form in this. Tickplex, I want to show you some results of my daily work with it and to discuss with you. This was a patient with, you can see it, with no antibodies against the whole spirochete. So, but antibodies IgG against round bodies. And it's going this way, and it's 2.700, which we find in this ELISA. So this is a patient where you will miss by a conventional ELISA, or where you will miss and misdiagnose by Western blots, because Western blots are not detecting the round body antibodies. I think they will in the future, but no other producer is on the way actually. But in the future, I think we need to include also the round body antibodies in the Western blots. The question is, how can we do that? This is a next patient I want to show you. This patient had CD3 cells low, which is for me a sign for chronic virus infection, or borderline low, 984. This patient had very low CD57 cells, so I can say this patient surely has some problems with some bacteria like Borrelia, like Chlamydia, like plasma, like Bartonella, whatever, or Streptococcus, whatever you think about that. And you can say these are the patients, all have pain of these patients, and they are really sick for longer than 1 year. The same patient, the Tickplex, showed IgG antibodies and the pleomorphic forms and IgG IgM, and you can see the round body in a weak positive ratio 0.937, but the round body IgM was also positive 1.276. So this is a very sensitive method, and what you can see by this, we find IgG and IgM antibodies in this patient against Borrelia burgdorferi. The Babesia microti IgM was also weakly positive. The Bartonella IgG in the same patient was weakly positive. The Bartonella henselae IgM was weakly positive. The Rickettsia acari IgG was negative. The Rickettsia acari IgM was weakly positive in this patient. The parvovirus, which is also included in Tickplex IgM, was weakly positive. Mycoplasma fermentans IgG negative, IgM positive. Going back to summarize, we found a lot of positive IgMs and some IgGs, and I think it's interesting to discuss that case a little later, what you can do with this case. In my opinion, I don't know the symptoms of this patient. Laboratories doing services, so we don't know all of this patient and all of the symptoms and not the differentials behind that. But this is now the job of the doctor in front of the patient to correlate this result with these results or positive results with a clinical suspicion. And if it fits to the clinical symptoms, these laboratory test findings, the positive or weak positive ones, support the clinical diagnosis. This is the way all doctors in the world work. Tickplex results from another patient. To show you another example, we found in this patient weak positive Borrelia burgdorferi IgG antibodies and weak positive IgG antibodies against Borrelia and Babesia, also IgG, no IgM antibodies. We found IgG antibodies against Bartonella by Tickplex, not Bartonella henselae. We found Ehrlichia schaffensis IgG positive. We found Rickettsia acari IgG positive. We found Rickettsia acari IgM negative. We found Coxsackie subtype A16 IgG positive. This interesting IgM was weakly positive. We found IgG positive for EBV, but the IgM was weakly positive. Human parvovirus IgG was weakly positive. In this patient, I would assume that it's more in the virus direction, because we have some weak IgM positivities, and the doctor in front of the patient needs now to decide, is it really a virus infection, or maybe it's some other infection in this case. Yes, what I would say to this, the IgG means if you find IgG without IgM, what we have learned in laboratory medicine, it's a former infection. If you find IgG plus IgM, as I told you before, IgM is a marker of chronic, persistent reactivation or current fresh infections. If you find just IgM antibodies, this is the marker of a really very fresh infection normally. We have the discussion also a lot about this if we have some polyclonal stimulation. This is very interesting point. So for me, if you find a lot of IgM antibodies in your case, you should check IgG, IgA, IgM in total if there's a quantification and elevation of the IgM in total, or maybe IgA, and you should do protein electrophoresis to check this. And some of these patients, they can develop monoclonal gammopathies. This is also not so nice to get by chronic infection, but please ask your doctor if the doctor cannot check protein electrophoresis and immunoglobulins quantification if you find a lot of IgM positivities in this test system. The basic diagnostic tests for chronic Lyme, my opinion, where I'm working, Tickplex is for me very helpful in Lyme disease. The basic variation, we have very high sensitivity, and I named specificity 99%, Leona, sorry for that, it's 98%. Sensitivity is 95%. You can see the ELISpot for the current activity, it's sensitivity 84%, specificity, depending on the study, 82 to 100%. You never will find a test system, as I mentioned before, 100% specificity and sensitivity. And also the CD57 cells are a very unspecific marker for bacterial infection, but important to know about that. CD3 cells are important for chronic virus infections. Maybe in a short summary of all of this information, which will be sometimes a little irritating, we don't forget that we are talking about test sensitivities and test specificities, but for me more important is the specificity to do the specificity in front of the patient, because the doctor makes the result specific and the laboratory cannot do it specific. We cannot exclude 100% unspecific reactions in the test system. On the other hand, we have very high specific antigens in this test system, and where Tickplex came from, very sensitive test system for round bodies and co-infections. So thank you very much for your attention, and I hope for a lot of questions.
Okay, I'm going to just interject here while Kunal is setting up the questions. And actually I did see through the chat, there was a few questions there, so I could maybe elaborate on those questions. One was about the round body. So traditionally we are taught that Borrelia has one form, and that's the cork-like screw structure. But we have seen over the years, not just us, but other scientists have seen and provided in immense literature to actually show that Borrelia actually can change its shape, and call this pleromorphic phenomenon, or pleromorphic forms, as the forms that they actually make. And just to highlight, in one of the slides that I had, showed that actually the spirochete, its outer membrane, actually bulges out to the point that actually its protoplastic cylinder inside that's carrying the genetic material actually coils itself in this sphere-like structure. And this ball-like structure, sphere-like structure, actually has its outer membrane and its inner membrane. So it has its membranes, and it's intact. If it didn't have its cell wall or its membranes, the protoplastic cylinder will not coil up on itself, and it would also just spew out. And we have shown this in our research. Marilyn in 2015 showed in our research that actually this sphere-like structure can be induced by adverse environments. And once, like water, like pH, like basic solutions. And also we show in that publication that if you put the spirochetes in sera, human sera, okay, that these sphere-like structures are induced. So they quickly turn its spiral form into a ball-like structure. And we show in an electron microscope in this paper actually that they have an intact cell wall. So the cell wall deficient term is incorrect, and we have used a term that was was used by others, and it's called round body because it has its genetic material. It has its outer and inner membranes are not degraded, and it's intact. And we all have also showed that when you put the round body, bring it back into its normal environment, its culture media, that it actually reverts into back its parent form, its spirochete form. So I hope that answers the questions about the round body. So I'm going to actually now give this over to Kunal, and he's going to entertain reading the questions that we will have.
Thank you, Dr. Armand. Thank you, Dr. Leona, for the presentation. What we have over here are a few questions. Everyone else can still write their questions. I'm still going through the chat, but here is the first question. Can you see it?
Yes, we can.
Okay. So I think this can be answered both by Dr. Armand and Dr. Leona.
Armand, do you want to start, or do you want me?
You can start, Leona. I can
Okay. So the question is, as you can read, in some cases, IgG is positive and IgM negative. The clinical presentation appears as a current infection. It is reasonable that the antigen-antibody complexes would explain this. And what else can explain this, given the 0.6 false positive? So there have also been other questions in the chat that I have seen that shows actually if there is an IgG, is that active, or is it dormant, or is it, you know, a past infection? And what happens if we have only IgM positive? Is that current active infection? And I want to say that traditionally, your immune system is set up that the first antibody you get obviously is an IgM, and then that shows an active infection. But then IgG comes up about 3 to 4 weeks later, and the IgG stays considerably longer than the IgM, but eventually they should go down. But there has been profound evidence in literature of people reporting that there is an immune dysfunction occurring in these patients that have been long-term suffering from Lyme disease. And when I say immune dysfunction, I mean there has been report cases where after antibiotic treatment and their symptoms have subsided, that they actually have high levels of IgG or high levels of IgM. And there's other studies that even patients that have developed actually arthritis, Lyme arthritis, they have long-term antibody signature, even when tested year after year after year. One of our greatest scientists, as we think here, actually reported even after 20 years in these patients that have been suffering long-term of Lyme disease, they have these levels of IgM or IgG in their system. So there is this immune disparity, and that's the point that in some patients they follow the traditional IgM, acute IgG, present or even past infection. But as Armand could actually support this following answer, is that despite the immune dysfunction that could occur in some of these patients, you have to look at the symptoms as well as the test results, and then of course then the clinicians will take both knowledge and other test result knowledge and then make a treatment course. And then there has been some cases where Tickplex has been negative, and then they have been through treatment, and then they're starting to see antibody signature showing up. And actually, we have seen those cases as well, and we would really like to publish more of those cases because it's showing that this initial negative result was because actually the individual is immune compromised, indicative of the CD57 being so low. Their system, they're not able to actually make antibody, but as soon as their immune system gets fit enough to produce antibodies, then they start showing up. And we're working with some clinicians to actually follow that progress, that this Tickplex is valuable in screening patients at first it's negative, but through the treatment, of course, you can see then that the immune system is getting fit, and then the antibodies are showing up. So there is a lot of immune disparity, and it can be obviously difficult in some clinicians, but I think the point is you look at the symptoms, you look at the test results to really help the patient. Armand?
Yes, in this case, if you have a high positive IgG without IgM, we find that also in normal ELISA in virus infections, for example. So higher titer of a higher extinction, we need to correlate this, can mean that the IgM is suppressed simply in this phase. On the other hand, the immune complexes can be one of the explanations. Sure, we have a lot of these explanations. The next one is also that IgM is systemic marker. So IgM is a very big molecule, and in localized infections, the tendency is moving more to an IgA production, which is not yet available in the Tickplex, but I know that, Leona, for sure you're working on that. Also, CDC is working on IgA for Borrelia testings. So the IgM, if it's evident, if on the other hand, if you find IgM in this, this is really something problematic. Something's happening with the immune system. It's a boostering, a massive boostering, and we are dealing not with fresh infections. We are not dealing with bullseye rashes in these cases. We are dealing with sometimes very, very sick chronic patients, and you have different immune situations. We had one question also in this. It said
I'll
now.
be going through the other questions.
Yeah, maybe to summarize in this, somebody asked, our patient is fine, IgG is there. IgG is a normal immune protection. Don't forget that. We have a lot of IgG in our bodies without any symptoms for these infections. Also, if you do vaccinations, we produce IgG antibodies, this protection, but not in Lyme disease. We all know that. But IgG is a natural immune answer. The IgM is, for me, a marker where we have really a problematic patient in front of us, if positive.
Okay, all right. Thank you, Dr. Armand. No, of course, thank you. So the next question is for Dr. Leona Gilbert.
Yes. So how do you control for non-specific immune responses? For example, someone with biotoxin illnesses or immune diseases. Also, some patients positive and Tickplex by negative on a Lyme spot or Lyme spot. So how we control for this immune non-specific immune responses is fundamentally we control it for the peptides that we're using in the test kit. We have chosen statistically to give us less non-specific binding to these peptides. So we're not using full lysates of any microorganism basically in our test kit. In addition to this, we have a cross-reactive buffer. It's proprietary that we put our peptides in, and we use it within our test kit to actually eliminate the non-specific responses. And this is commercially available even for other test kits as well. And then, of course, I have to go back to the peptide or the proteins that we're using. We're making sure that they're very specific from the onset against the microbes, and we test them against the different microbes to see if they're very, very specific. And then this is always a question that's interesting about Tickplex positive and Tickplex, or Tickplex being positive but the Lyme spot being negative. So I want to point out that these are completely two different types of tests. So Tickplex is analyzing your antibody response, and a Lyme spot is actually screening the cytokines that are coming off of the immune cells. Okay, and these immune cells that are coming from the patients that have been stimulated with Borrelia, let's say Borrelia antigens. So once screening, the ELISA is screening for the immune cells and specifically the T cells, and Tickplex is screening for antibodies. They're both indirect tests, so they mean different things. And I know that a Lyme spot has correlated to active infection, and that's really nice. Tickplex, of course, depending on the individual, if they're a chronic patient or persistent patient, will they have an immune disparity or not? But you can really see that the immune disparity is seen in these patients that have persistent infection. So I'm not saying that Tickplex and the Lyme spot has to be both positive. We have seen in this case, one positive, one negative, and vice versa. But I think the point is we have to look at the overall immune fitness of the individual to see where can be going wrong in the individual, that we could actually more help them and boost up the immune system, so that we start having both the immune cells working, functioning, as well as the B cells actually making antibodies. So this is what we have to really look at. So the two different tests. I hope this answered your question.
Okay.
Armand, do you have anything to add, or?
It's completely correct. Tickplex is Th2 testing, ELISpot is Th1 testing. Both immune answers complement each other, but we have patients with individual T-cellular immune deficiency syndromes. We have patients with B-cellular immune deficiencies. We have some with combination. So this individual thing. And if we compare sensitivity data, for example, what you showed, Leona, 95% in Tickplex, Borrelia, we have in ELISpot 85% or 84. You cannot say now 100% of chronic Lyme patients should have all positive immune answers in both levels.
Great. All right. So then the next question is, I think, more for Dr. Armand first.
Oh, yes. From other countries, it's really unproblematic because this is a serum tube. The antibodies, proteins are easier to transport by logistics. You can send all over the world. That's no problem. It's not so time critical. Have to be careful with hemolysis. So maybe some doctors can centrifuge that. Costs are for the basic around, let me check, it's around 70-80 euro. The Tickplex basic, but if you do the complete, it's 20 antigens in the test system. It's 400 something over 400 euro. But if you compare with other test systems and the information you get by Tickplex, it's a massive coming forward in this.
Okay, and I think for further information, anyone wanting to order the test kit can write to info@armandlabs.com.
Yes, I'm not the only laboratory doing it.
Yes,
some other laboratories are also offering now Tickplex because it's an open test system. It's not a home put. It's not an in-house. It's externally controllable test system. It's certified, and Leona showed all of these criteria we are doing. So some other laboratories are also offering that.
Right. I think we can address this more in the survey and follow up with the attendees. Okay, I think then the next question is both for Dr. Armand and Dr. Leona.
Yeah, this is interesting. I think this is a question that actually always comes up, because there's some tests, some people have said that, well, it doesn't matter because you're only screening antibodies. But I think as a scientist, the logic is this, and because the Tickplex is so new, again, we need more case studies with this. So I would really like to encourage clinicians to work with us so that we can, report this. But if we lose, or if we use the logic, Armin went over that, IgM has a half-life of 5 days, IgG has a half-life of 21 days. And if you're taking any kind of treatment that is supposed to affect your immune system, then of course, are you really getting kind of like the proper signature from your immune system if it's being boosted, or if it's being suppressed, and so forth. So we recommend that, I recommend that you stop treatment, but I can't say that because I'm not a clinician, but this test kit is valuable if your immune system is at a steady state, okay, and then you have a blood drawn. And Armin, I'm not sure what you think about this, but this is something that we have addressed scientifically here with our test kit, and it's best that the patient has a steady immune system that we could actually test, from 1 week to the second week to the third week, that they're pretty stable. So, Armin?
Yes, to add something, I think it's a very interesting question because what we see, and Professor Baron worked on that on PCR during therapy. So he found more PCR positive samples for Borrelia than without treatment. That means, for example, if you have an Herxheimer reaction, so that means a higher concentration, a higher load of bacteria coming out from the cells maybe or destroyed, and then you surely have higher immune response levels. So it's a
Absolutely.
higher chance, in my opinion, to detect positive Borrelia spots and also Th1 immune reactions than without treatment, because the really sick patients I see by spots don't react in spots, but during treatment, the immune system is jumping on, and then they produce antibodies again, and the T cells are coming up again. That's a very interesting question. Maybe we should not diagnose before treatment. We should switch during treatments.
Yeah.
All right. And then this next question again, I think, is for both Dr. Armand and Dr. Leona.
So what if there is no immune antigens due to the Borrelia shutdown? The immune system. Yeah, I have to say that we have seen this in our with our patients. We have seen this with our test kit that if the CD57 is low, it correlates to no immune response or a compromised immune response, and that indicates that there's difficulties in producing antibodies. So of course, then that correlates to a negative result. And I'm not saying it's a false negative, but I'm saying that because of the immune system being so weak, they're not able to make antibodies. And that obviously means that there's no seroconversion as well from IgM to IgG. There's an immune dysfunction occurring. So unfortunately, we can see this in patients because it correlates also with how long they have been suffering, and as well as low CD57. And we also can correlate this, that upon improvement, then they start developing antibodies. So this test kit can actually be used in those situations alongside with the CD57 to see if the immune system is fit enough to actually be functional. So, and what do you think, Armand?
Yeah, this is also important. In this case, if you're not sure about, please check the IgG total and do IgG subclasses if it's low. We have studies about IgG1 and IgG3 subclass deficiencies, which means low in chronic bacterial infections. This is accepted, and some therapists, for them, it's very important to use IVIGs, and they are successful in supporting your natural immune response by using IVIG therapies, for example. So you have possibilities to find that out. On the other hand, we have a problem if you are infected with some Borrelia subspecies which block the complement way. So an antibody is just working with complement. Otherwise, Borrelia cannot be destroyed. So if you're not sure, there is some testing C3A, C4A, but this is difficult to send because you need dry ice for that. It's a complement testing.
All right, we have time for two more questions. So this next question is, I believe, for both presenters.
Yeah, I think we have touched this, meaning that if an initial test result is negative, most likely their immune system is low, or they're having difficulties. Right. Yeah. So I think we have.
And then this one.
Maybe I can add something to that. The way internationally also CDC is going to the way of a Th1, Th2 shift. And from came a paper which Dr. Sandström sent me last week, which is all very interesting in the prognosis. So I think in the future we will check also Th1, Th2 balances, and by Th17 the autoimmune disorders which can develop from this. So it's more and more the way of the balance. It's a balance question, and also some of therapies are working on that.
Okay, we have this one last question available.
So are we doing testing of skin infections due to tick borreliosis? No, Tickplex is designed for serological, so antibodies really specifically coming from sera, and not testing any other parasites except for the Babesia, and yeah. So I think that the skin testing is skin. It would be interesting, but unfortunately, at the moment, we're not pursuing this.
In the skin, you will also find Th1 reactions, and we can check the skin by a PCR, by a biopsy, and also for Leishmania. We can check this. For Leishmania, we have also antibody testings in the blood. It's not, I think the message is it's not everything Lyme disease. So Leishmaniosis is also very common in the world. And maybe also to mention in the Tickplex, there are not all infections in the world you can detect by this. These are the most common infections in the complexity of tick-borne diseases and chronic multiple infections.
Yeah.
All right. So I think those were all the questions that we had. With this, I would like to close the webinar. For people attending from the US, a very good morning, and for the people from Europe, good night. And thank you very much for your time. Please fill in the surveys. Greatly appreciate your time. Thank you.
Thank you.
Bye-bye. Thank you.
Bye-bye.
Bye.